So today we'll be going through how to safely transport a patient with a chest tube and an underwater seal drain. So a chest tube will commonly be placed to facilitate the re-expansion of a lung post pneumothorax, tension pneumothorax, hemothorax, etc. And this will assist to improve ventilation. The care of the patient with the chest tube is usually indicated when a chest tube and underwater seal drain is being used while transporting the patient from scene or during an inter-hospital transfer. Alright, so now we have a patient with a chest tube and an underwater seal drain that needs transporting. Let's go through the equipment that we'll require. We'll require a patient with a chest drain. This will be connected to an underwater seal drain seen here on the cardboard. This may be required to be connected to suction, so we'll need a suction unit available. We'll need oxygen in case the patient requires some oxygen. We'll need our observation equipment, cardiac monitor. The patient may continue to require analgesia, so we'll have our kit ready with all the medications that we may need. We'll hopefully have a ability to do a needle decompression if the whole system fails. Hopefully we'll be able to carry a spare underwater seal drain with us. And we'll have sterile water handy as well if we don't. So prior to transport, first we're going to check the site where the intercostal catheter has been inserted. So we're going to check that the sutures are intact. If it's not already dressed, make sure the dressing is occlusive and no inlet portals are visible and they're all within the cavity. Secondly, we're going to do a full baseline set of observations and a primary survey. We'll listen to all lung fields. And so on. And as I said, full set of observations, blood pressure, oxygen saturations, cardiac monitor, temperature, BGL, rest rate, do it all. We're going to have the patient in a position of comfort, whether that's in a semi-Fowler's, high Fowler's or supine position, as long as the site is not being disrupted. We're going to do a pain assessment on the patient and deliver analgesia as required. We're going to ensure that the drain unit is below the patient at all times, and the tube is not laying on the floor. We're going to observe that there are no kinks in the tubing either. Now we'll discuss the ongoing observations for the underwater seal drain during the transport. So if suction is required, we're going to have the suction hooked up. We're going to have the suction turned on until the suction bellow reaches the triangle, and the suction can be adjusted on the side for this dial to whatever has been required. We're going to make sure that the sterile water in the chamber is at the 2 centimetre line. When the patient, during the respiratory cycle, we might observe a swing. The ball will come up the chamber there. If we're not observing a swing, it's either there's a block in the tubing or the patient's lung is fully re-expanded. We're going to note the quality and amount of fluid coming out of the drain, and we'll mark it off as we go and the time. Anything over 100 to 200 mils in an hour is deemed significant. We might note some bubbling if the tube has been inserted for a pneumothorax. We might note a bit of bubbling at the end of a small amount at the end of the respiratory cycle. There are numbers here from 1 to 5, and that helps us describe the intensity of the bubbling. If the bubbling is coming up at the 5, then that will be a large amount of bubbling. Now lastly, just some considerations to think about while transporting the patient with a chest tube. First of all, do not clamp the tube, as this may lead to the development of a tension pneumothorax. If you need to replace the underwater seal drain at any stage, then only clamp immediately prior to disconnection and disconnect as soon as the new underwater seal drain is connected. Now bubbling. If you notice continuous bubbling, then this is an issue. This indicates that there is an air leak in the system somewhere, anywhere between the patient and the underwater seal drain. Now, you should first start checking at the patient, check at the site where the drain is, make sure that the inlets are all within the pleural cavity, make sure all the connections are tight. On the chamber, you'll notice that there's a 1 to 5 around where the water is. This indicates the severity of the bubbling. Usually you'll see with a patient with a tension pneumothorax or pneumothorax, you'll see that the bubbling might be at about a 1 at the end of the respiratory cycle. Now, this is normal. If you notice bubbling is getting more worse and it is constant, then this is cause to look for an air leak. Now, oscillations within the water chamber is normal during the respiratory cycle, and this is where the ball will rise with each breath. The absence of oscillation might indicate that the tube is blocked or the lung has fully re-expanded. If you think the tube might be blocked, then assess the tube for the blockage. And if the underwater seal drain is malfunctioning, replace it or place the end of the tube into 250 mils of water 2 to 4 centimeters down to create the underwater seal. One thing to note is oscillations may not occur if the lung has fully re-expanded or if the unit is connected to suction. Do not turn the suction off just to observe for the oscillation. Now, speaking of suction, this will only be indicated if an air leak is persistent or the lung does not fully re-expand after the insertion of the chest tube. If required, minimal negative pressure should be applied initially. If re-expansion occurs too rapidly and you've turned the suction up too much, this could cause a re-expansion pulmonary edema. Now, thank you for listening. This is how you transport a patient with a chest tube and underwater seal drain safely.